Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine. And silver level sponsor, Hanger Clinic.
Shepherd Center specializes in medical treatment, research, and rehabilitation for people with spinal cord and brain injury.
We see 400 individuals with brain injury a year. We see over 350 individuals with spinal cord injury a year. Our staff have the expertise, we have the knowledge, and our outcomes exceed national averages.
Today, we will be presenting our scoping review of quality of life assessments that can be used for patients diagnosed with amyotrophic lateral sclerosis. This scoping review was conducted by Hannah Prescott, Mallorie Savage, Addie Broom, Emily Crawford, MacKenzie Franklin, Teal Benavides, and Stephanie Johnson. Our objectives for this presentation are that by the conclusion of this session, participants will be able to compare and contrast quality of life assessments that will be effective for clients with ALS, use data from a scoping review of the literature, define and apply health-related quality of life, define and apply global quality of life, choose the most frequently used and validated quality of life assessments to apply to clients in a clinical setting, and lastly, to use our descriptive information within occupational therapy practice. Before we delve into the details of our scoping review, some common abbreviations used during our presentation include ALS, which stands for amyotrophic lateral sclerosis, QOL, which stands for quality of life, HRQOL, which stands for health-related quality of life, and PALS, which stands for people with amyotrophic lateral sclerosis. So these are our pre-test questions. Number 1. On a scale of 0 to 10, how comfortable are you with treating patients with ALS? Number 2, briefly explain the difference between global quality of life and health-related quality of life. Number 3, in your opinion, are health-related quality of life assessments or global quality of life assessments more beneficial to use with PALS, and why? Number 4, list one assessment that could be utilized to identify health-related quality of life within PALS. Number 5, list one assessment that could be utilized to identify global quality of life within PALS. Number 6, why is quality of life important in PALS? And number 7, how does knowledge of the different quality of life definitions impact practice as an occupational therapist? So the purpose of this scoping review is to examine the available assessments that are used for measuring quality of life in patients with amyotrophic lateral sclerosis and present the need for a consistent definition of quality of life and an assessment for these individuals.
When discussing quality of life, there are two key terms we want you to be aware of. First, global quality of life. Global quality of life is considered to be more subjective than health-related quality of life, since it accounts for non-medical factors such as mental status, emotional response, and social well-being of individuals, all of which can be observed through interpersonal relationships and social support. The second term is health-related quality of life. Health-related quality of life often consists of comprehensive patient status, by focusing on physical health and functional ability of the individual. The use of quality of life measures for people with neurological disorders has been relatively limited, and this has certainly been the case for PALS. Currently, a gold standard assessment has not yet been developed to measure quality of life in PALS, but several assessments have been used, which will be discussed later in our presentation. Within the global and health-related assessments that are used in this population, there is not a specific quality of life definition among them, resulting in the lack of a consistent measure of quality of life. ALS has substantial adverse effects upon both functioning and well-being of an individual. As such, focusing on quality of life is key. Measures specifically designed for PALS to move forward in research and to optimize quality of life may help in the overall OT process to better meet our clients' needs. Defining quality of life in PALS is challenging because of the fast progression of the disease and the short life expectancy of 2 to 3 years after symptom onset. When assessing the quality of life in PALS, it is important to understand the response shift that occurs. A response shift is seen when factors that are most important to an individual with ALS change throughout the disease process. Often, this response shift contributes to a phenomenon in which the overall quality of life tends to stay the same or even increase throughout the disease progression, but the factors that are most important to the individuals change. Overall, the gaps in the literature that we wanted to address in our research was that there is no consistent definition of quality of life used within the ALS population, which leads to the lack of a consistent measure of quality of life in PALS, since quality of life is defined differently by different assessments. The lack of a clear definition also causes an inconsistency to occur in the accuracy of the assessment interpretation and comparison of the data collected by different assessments. The current literature indicates that there is no widely accepted assessment that is used to accurately measure quality of life within the ALS community. Since there is no gold standard measurement for assessing quality of life in PALS, or even the factors that are most important for them, we wanted to know what quality of life assessments currently are in use for patients with ALS. Additionally, since we know that there is not a commonly accepted definition of quality of life, we wanted to determine what the most commonly accepted quality of life definition was for PALS.
We conducted a scoping review, which is a type of knowledge synthesis that uses a systematic approach to map evidence on a topic to identify main concepts, sources, theories, and knowledge gaps. We used a scoping review to present information on the available assessments rather than to report on the quality of the articles and to determine the gap in the literature regarding quality of life definitions. We searched 6 electronic databases during our scoping review, and they were PubMed, CINAHL, Cochrane, TRIP, HAPI, and ProQuest Nursing and Allied Health Database. We utilized a 3-step screening process to identify articles. The first step was the title screening, then abstract screening, and then a full text screening. This graphic is our Prisma flow diagram, and it represents our 3-step screening process that we utilize and that I introduced on the previous slide. It includes how many articles that we included and excluded at each step. As a group, we composed the search string on January 14, 2020, and completed it on February 17, 2020. We combined the search terms of ALS, quality of life, and assessments, along with similar terms to generate an ample article matches. We use the term "and" to group like terms and the term "or" to combine groups of terms. We tested the search string prior to the medical librarian reviewing it. Then the librarian modified the search string to yield the most accurate results on the various databases that we searched. For the first step of the screening process, we divided the databases and pages on the database to screen the titles. We picked titles that related to ALS and quality of life assessments and entered them onto a Google form and saved them on Google Sheets. And after this, we had 235 articles and then 196 articles when the duplicates were removed. Then we did an abstract screening of the articles. We screened the articles in pairs and discussed any disagreements about the inclusion of the article. The inclusion and exclusion criteria that we use will be discussed on the next slide. And this resulted in 92 articles for our abstract screening. Lastly, we then did a full text screening. We also did this in pairs and discussed any disagreements within the pairs. And then we did it as a group if the decision could not be made within the pair. The final number of articles included in our scoping review is 67. This graphic shows the inclusion and exclusion criteria of our scoping review. The inclusion criteria for our search was as follows. The article must address quality of life, which could include health-related or global quality of life. It also must include an assessment of quality of life, which can include disease-specific or non-disease-specific assessments. The article must also relate to PALS and be written in English. Lastly, articles included in our scoping review must have been part of a peer-reviewed journal. The exclusion criteria was that the articles solely focus on caregivers to those with ALS, assessments that focus on depression and/or anxiety, assessments that were pediatric were also excluded since the majority of ALS cases occur in adulthood, and we did not search any of the gray literature. In regards to the data we extracted from the articles, we did not extract the level of evidence of the articles since we performed a scoping review and not a systematic review. However, we did extract a variety of information from the articles, such as the quality of life definition that was used in the article. We also extracted the psychometric properties of the assessments, such as the validity, reliability, sensitivity, and responsiveness. We also extracted the components of the assessments, such as the domains of quality of life that the assessments determined, the response scale that the assessment used, and how the assessment was delivered, such as was it an interview or was it a self-response questionnaire. Lastly, we extracted the overall description of the assessment and the type of quality of life that the assessment measured, meaning whether it was global or health-related quality of life. We also determined if the assessment was disease-specific, meaning that it is specific to the ALS population, or if it was non-disease specific. As a refresher from what Emily went over, I will reiterate the difference between global and health-related quality of life. Global quality of life relates to the overall well-being of the person, and it can account for non-medical factors such as their mental status, emotional response, and their social well-being. Health-related quality of life, on the other hand, relates more to the person's physical well-being, such as their physical health and functional ability. In occupational therapy, the difference between global and health-related quality of life is very important, because as a profession, we care about the whole person, which is measured by global quality of life, and not just the physical aspects, which are measured by health-related quality of life. To answer the research question, what are the quality of life assessments that exist for patients with ALS? We determined the different assessments that were mentioned in the articles included in our scoping review, and the type of quality of life that they measured, and if it was specific to ALS or not. This graphic is a flow diagram of the 35 assessments that were identified in the 67 articles that are included in our scoping review. 80% or 28 of the assessments were non-disease specific, meaning that they were not specific to the ALS population. 7 of them were disease-specific assessments, meaning that they were specific to the ALS population. We then divided the assessments by global quality of life and health-related quality of life. The percentages for global and health-related quality of life are based on if they are non-disease specific or disease specific. Therefore, 37.14% of the 28 non-disease specific assessments measured global quality of life. Examples of non-disease specific global quality of life assessments are the McGill Quality of Life Questionnaire and the Schedule for the Evaluation of Individual Quality of Life. And 42.86% of them measured health-related quality of life. And examples of non-disease specific health-related quality of life assessments are the 36-item short form health survey and the Quality of Well-being Scale. There were 5.72 more non-disease specific assessments that measured health-related quality of life versus those that measured global quality of life. And from the 7 assessments that were disease specific, 8.75 or 3 of them measured global quality of life. Examples of disease-specific global quality of life assessments are ALS-specific quality of life instrument and the ALS-specific quality of life short form. And 11.43 or 4 of them measured health-related quality of life. And examples of disease-specific health-related quality of life assessments are the Sickness Impact Profile ALS 19 and the ALS Assessment Questionnaire. Similar to the non-disease-specific assessments, more of the disease-specific assessments measured health-related quality of life than global quality of life by 2.86%. Therefore, this graphic shows us that a majority or 80% of the assessment used for PALS were non-disease specific, and more of the assessment measured health-related quality of life than global quality of life. However, the difference was low because it was less than 6%. Therefore, most of the assessments currently used on PALS are non-disease specific health-related quality of life assessments, meaning that these assessments are not specific to ALS and do not account for factors outside of the physical and medical environment that could affect quality of life, and that we know to affect quality of life because of the changes that take place throughout the disease process that is seen through the response shift.
This pyramid graphic represents the most frequently used assessments that were identified from our scoping review, with the non-disease specific health-related quality of life assessments accounting for the greatest number of assessments found, as shown at the bottom of the triangle, and ending with disease-specific global quality of life assessments at the top of the triangle, which accounted for the smallest frequency and percentage of assessments found within our scoping review. In the 67 articles, quality of life assessments were mentioned for a total frequency of 154 times. To determine which assessments were used the most often, the total frequency of how many times the assessments were mentioned in the articles were determined. The most commonly used assessment and the most commonly used non-disease specific health-related quality of life assessment was the Short Form Survey 36, or the SF-36. This was mentioned 24 times, or 16% of the time, when including the German version. There were 2 commonly used disease-specific health-related quality of life assessments, including the Amyotrophic Lateral Sclerosis Assessment Questionnaire, or the ALS AQ40, and the Sickness Impact Profile ALS 19. These are both mentioned since they only differ by being mentioned 1 time less than the other. So the Sickness Impact Profile ALS 19 was mentioned 10 times, or 6.67% of the time, and it is a shorter version of the original Sickness Impact Profile. The most frequent non-disease specific global quality of life assessment was the schedule of evaluation of individual quality of life, also known as the sequel, and the sequel direct weighting, which was derived from the previously mentioned assessment. So the sequel direct weighting was mentioned 13 times, or 8.67% of the time. The sequel was mentioned 7 times, or 4.67% of the time, and when the two assessments were combined, they were mentioned for a total frequency of 13.33%. So lastly, the most commonly used disease-specific global quality of life assessment is the ALS-specific quality of life instrument, also known as the ALS-SQOL, and the ALS-specific quality of life instrument revised. It was mentioned 10 times, or 6.67% of the time. So these are the most frequently used assessments that I discussed about in the previous slide. So the short form 36 is a non-disease specific health-related quality of life that measures 8 dimensions of quality of life in 36 different items. It scores a physical summary component consisting of 4 domains of physical functioning, role limitations due to physical health problems, bodily pain, and generic health perceptions. It also scores a mental summary component consisting of the 4 domains of vitality, social functioning, role limitations due to emotional problems, and mental health. Higher scores obtained suggest a better and more favorable health status. The amyotrophic lateral sclerosis assessment questionnaire is a disease-specific health-related quality of life. It measures 5 areas of the health state, including eating and drinking, communication, ADL and independence, physical mobility, and emotional functioning. It contains 40 items, and questions are scored based on the frequency of a particular problem that the individual experienced within the past 2 weeks. The Sickness Impact Profile ALS-19 is a disease-specific, health-related quality of life assessment. It contains 19 questions that are yes or no and are specifically related to PALS over the course of ALS, and they measure what has the greatest impact on quality of life. The score is then normalized to a 100-point scale. The schedule for evaluation of individual quality of life direct weighting is a non-disease specific global quality of life assessment, and it consists of a semi-structured interview that is about the subjective aspects of quality of life. So the patient picks the 5 most important areas of their life, currently which is called a Q. They then rate the level of functioning for their Q on a visual analog scale from the worst possible quality of life being a 0 to the best possible quality of life being a 100. They also rate the relative importance of each Q in a pie chart called the Q weight. An index score is then achieved and calculated from 0 to 100, with the higher score representing a higher perceived quality of life. The schedule for evaluation of individual quality of life is very similar to the sequel direct weighting. However, it has open-ended questions that are factored into the score, and this is what gives insight into the factors which determine one's quality of life, the ability to think abstractly, and the ability to make judgments based on information presented in a diagrammatic form. And this is the assessment that is more often used in research. Lastly, the ALS-specific quality of life instrument and the ALS-specific quality of life instrument revised, which was modified to be shorter and easier to complete. These are both disease-specific global quality of life assessments measuring overall quality of life in 6 areas involving negative emotion, interaction with people and the environment, intimacy, religiosity, physical symptoms, and bulbar function. The average of the scores is then determined to assess total quality of life. After determining the 35 assessments that were used for quality of life in people with ALS, We also wanted to determine the different components of the assessments that were used, such as the response scale that the assessment scored the participants on, such as a Likert scale, open-ended questions, and visual analog scales. The domains of quality of life of the assessment were also measured, including physical, psychological, social, environmental, cognitive, and family aspects. We also want to see whether the assessment was a standardized measure to be able to compare results and findings across the ALS population, or was it non-standardized, the responsiveness and sensitivity to change of the assessment, to analyze if the assessment could accurately monitor changes across the disease process, the reliability of the assessment, such as internal consistency, which reflects the extent to which items within an instrument measures various aspects of the same characteristics or constructs, and the validity of the assessment as a way to gauge how well a test or survey is actually measuring what you want it to measure. So the most commonly used response scale was self-report questionnaires for a frequency of 27, and the most common way they were measured was Likert scales for a frequency of 19, and the most commonly used Likert scale was a 0 to 10 point Likert scale for a frequency of 7. The most commonly measured domains quality of life that were measured in an assessment were physical, psychological, and social for a frequency of 10 times. After that, it was physical, psychological, social, and in addition, environment for a frequency of 6. Regarding standardization, 34 out of the 35 assessments were considered to be standardized, with only one of the assessments to not give any information regarding standardization. Responsiveness and sensitivity were not mentioned for 20 of the assessments and were only discussed for 13 of them. An example of sensitivity is that the 0 to 10 rating scale for the amyotrophic lateral sclerosis specific quality of life short form allows for more sensitivity to subtle changes in clinical symptoms throughout the disease process of ALS. An example of responsiveness is that the sickness impact profile ALS 19 is responsive to changes over time in the ALS and motor neuron disease patients, as the measure correlated well with symptom duration and health decline. However, the sickness impact profile alone was determined to be insufficiently sensitive for monitoring disease progression for ALS, relatively unresponsive to changes over time, and particularly in the categories that sum to give the psychosocial score. With regards to reliability, 19 assessments discussed reliability and 16 did not. An example of reliability is that the schedule of the evaluation of individual quality of life had a high internal consistency with a median of 0.81. An internal consistency was the type of reliability that was most frequently found throughout the assessments compared to other types of reliability such as inter or intra-rater and test-retest reliability. Lastly, validity was mentioned for 14 of the assessments, but not for 21 of them. An example of validity is that the amyotrophic lateral sclerosis specific quality of life short form is a valid, briefer version of the ALS SQOLR, and the subscales have construct, convergent, and divergent validity. To answer our second research question, what is the most commonly accepted definition of quality of life used for PALS, we sought out to find the definition of quality of life in each article provided. So of the 67 articles, only 26 of them, or 38.81%, provided a definition of quality of life. Therefore, the majority, 41 articles, or 61.19%, did not provide a definition. Additionally, of the 26 that provided a definition for quality of life, only 23 of them provided a citation for it. and the most commonly used citation was from the World Health Organization, or the WHO, definition. However, different years were cited. So 3 articles mentioned the WHO and did not cite them. 7 articles cited the WHO for various years, 1 for 1948, 2 for 1994, but from different articles, 1 from 1995, 3 from 1997, with 2 of them from the same article, and 1 from 1998. The most current definition from the World Health Organization mentioned in the scoping review was from 1998, and this states that quality of life is a broad-ranging concept affecting in a complex way by a person's physical health, psychological state, level of independence, social relationships, personal beliefs, and their relationship to salient features of their environment. The common theme throughout our quality of life definition synthesis was that the authors were aware of the diversity of the quality of life definitions, pressing the need for a more consistent quality of life definition and to distinguish factors in the importance between global quality of life and health-related quality of life.
At this point in our scoping review process, we were able to draw several conclusions. Throughout our review, we identified and emphasized high frequencies of non-disease-specific quality of life assessments compared to disease-specific quality of life assessments used for PALS. There were similar frequencies of the use of health-related quality of life and global quality of life assessments. Additionally, there is often not a clear distinction between global quality of life and health-related quality of life. This unclear distinction results in confusion among clinicians working with PALS about the factors of quality of life that are being measured and utilizing assessments that may be potentially falling short in measuring factors that are most meaningful to the client. Along with the general conclusions we were able to draw from the results of the study, we were also able to draw several OT-specific conclusions that we should be aware of when working with PALS. Overall, there is an undeniable need for an overarching, consistent, and holistic quality of life definition, along with an unambiguous distinction between health-related quality of life and global quality of life. In reference to the skilled scope of occupational therapy and the individually and functionally based quality of life, there remains the pressing need for the use of assessments that encompass a holistic view of the individual while identifying factors that are considered most important to them during their disease process and progression. Factors important to them may include their physical health status as defined in health-related quality of life, but PALS likely finds spirituality, social engagement, family dynamics, and other global quality of life factors just as important, if not more important, than their physical health. Thus, there is an obvious demand for greater clinical utilization of disease-specific global quality of life assessments to be used for PALS. The ideal quality of life assessment would capture the fundamental components that are individualized to PALS throughout their disease process, as supported by past and current ALS literature. As with any research, we identified a few limitations with our research that will need to be addressed if the study were to be replicated. As a group, we did not search the gray literature during the screening process. We did not go beyond searching PubMed, CINAHL, Cochrane, TRIP, HAPPY, and ProQuest Nursing and Allied Health database. In reference to data extraction, 2 group members extracted data at a time. The entirety of the articles were read and data was extracted from each article, but not by each group member. Splitting the data extraction between individual group members and cross-checking with only one other group member at each step of the screening process may have led to potential bias in data extraction. To account for this potential bias, inter-rater reliability was calculated throughout the review process. Additionally, when the pairs had a disagreement about the data extraction process that they wanted feedback on, the entire group would come together to discuss and reach an agreement. We screen titles as the first form of screening instead of abstract screening as the first form of screening, which may have limited the number of articles included in our scoping review. We used this method due to the high volume of articles that needed to be screened from the 6 databases searched. Finally, we did not formally evaluate the level of evidence of each article beyond it being in a peer-reviewed journal. Before we go into our case study, we wanted to reiterate the most frequently used assessments that we found in our scoping review. The short form 36, or the SF36, is a non-disease specific health-related quality of life measure with higher scores indicating a better and more favorable health status. The Amyotrophic Lateral Sclerosis Assessment Questionnaire, or ALS-AQ40, is a disease-specific health-related quality of life assessment. The Sickness Impact Profile ALS-19 is a disease-specific health-related quality of life assessment. The Schedule for Evaluation of Individual Quality of Life Direct Weighting, or the SEQUEL-DW, is a non-disease-specific global quality of life assessment. An index score is calculated from 0 to 100, with a higher score representing a higher perceived quality of life. The Schedule for Evaluation of Individual Quality of Life, or the SEQUEL, is very similar to the SEQUEL Direct Weighting and is often used more in research. The ALS Specific Quality of Life Instrument, or ALS-SQOL, also called the ALS-SQOL-46, and the ALS Specific Quality of Life Instrument Revised, which was modified to be shorter and easier to complete than the ALS-SQOL, are disease-specific global quality of life assessments.
Okay, so now let's apply everything that everybody else has talked about, and specifically within an ALS case study. So just to refresh, so remember, we have quality of life measures that can either be global quality of life measures or that can be health-related quality of life measures. What we do know from literature is that quality of life is really, it's a multi-dimensional construct. It is individualized, and that actually it can change and kind of meld with time as people change and preferences change. And that's why it's important that when we're thinking about quality of life assessments, that we really choose something that is key and honed in for the population that we're working with. So within global quality of life measures and within health-related quality of life measures, we have measures that are both disease-specific and non-disease specific. For PALS, well, what is most important and what's best or what is ideal? So we do know from the literature that for PALS, physical functioning and strength is not important for their definition of quality of life, but actuality, and well, in all actuality, psychological implications and psychological well-being is more important for quality of life and student quality of life than physical functioning. We also know that PALS quality of life over time doesn't necessarily decline, and that's quite often because that global quality of life, so those domains that are more related to maybe socialization or spending time with family or spending time with friends or completing leisure tasks, then those are factors that PALS identify more with. And so that's more global quality of life. And what we find and what the literature shows is that over the course of the disease span, even though their physical functioning may be declining, so their health-related quality of life, if you're measuring that, may decline, their global quality of life doesn't, because that's not how or what they're using to identify and define their quality of life, globally speaking, are factors that necessarily aren't changing. So family, friends, socializing. And so that's important for us to remember too. So let's take all of that and apply it to Mrs. Jones. So she is a 67-year-old little lady who has been playing piano in her church for about 20 years. She lives here in the South. She lives with her husband in a one-story home, and she loves to garden. She loves to have a glass of wine every night with her husband, and oftentimes they'll have friends come over and socialize, and they play a game of cards. She does have ALS. She was diagnosed with ALS about 7 months ago, and she's been coming to an ALS-associated multidisciplinary care clinic for about 6 months. So her symptoms are more limb. So she does have more upper extremity weakness than she does lower extremity. Her speech overall is pretty normal. She's 100% intelligible. It's just a little bit slower. And she finds that towards the end of the day, she just fatigues. And just in general, she just fatigues more so at the end of the day. She's still pretty independent though. So she's able to complete all of her ADLs. With modified independence, she just has to do them a little differently, and it takes her a little extra time. Her husband does have to intermittently help with tasks that are really overhead. Just because of her upper extremity weakness, she does have more proximal weakness than she does distal weakness. But she has modified her home to where she keeps things more kind of waist level and elbow level, so that allows her to complete tasks. Still with much more independence than you would actually think. And her goals, she just wants to remain active in her community. She wants to be able to keep playing the piano for as long as she can. And then she wants to remain active with her family. The assessments, so the health-related quality of life assessments, the ALS-AQ40 is a disease-specific health-related quality of life measure. And then the short form 12 is a non-disease specific health-related quality of life assessment. So when we think about the ALS AQ40, this is a scale that looks out the last 2 weeks. It uses a Likert scale, and it's 40 questions that fall into 5 different categories. So physical mobility, ADLs and independence, eating and drinking, communication, and then emotional functioning. So for example, a question, since this is a health-related quality of life assessment, a question for like ADLs or independence, it'll read such as following. So during the last 2 weeks, have you had difficulty using arms and hands? Or have you had difficulty in the last 2 weeks picking things up? Or difficulty holding books and turning pages? Or for example, physical mobility, that section, during the last 2 weeks, have you had difficulty walking short distances? Have you lost your balance while walking? So each of the sections, while they have themes for ADLs or eating and drinking or communication, they're all related around that physical functioning component. Even the emotional functioning section, like questions for it, during the last 2 weeks, I felt angry because of the disease, or I have been worried that I was a burden to others. And so it's all related around oftentimes those physical components, and specifically more strength and just kind of range of motion, so the ability to complete the task. When we think about the scale, it is a 0 to 100. So 0 meaning it is their best health, so their best ability to complete the task, all the way to 100, which is going to be like their worst. So when we look at Miss Jones, she rates everything, when we think about eating and drinking and communication, that's pretty low, so 0 being better. So that's pretty low. She's doing pretty good. But then she rates ADLs pretty high. So it means it's 70. So if 100 is her worst health, she's in the 70s. So that's meaning she's having some difficulties completing them. So even though she's still modified independent, she's just having difficulties physically completing them. And so that's why she rated that section a little bit higher. So then let's look at the short form 12. So this is a non-disease specific health-related quality of life measure. It does use a Likert scale, and instead of being like the ALS AQ40 over the last 2 weeks, the short form 12 is over the last 4 weeks. And the short form 12 is just a shorter version of the SF36, and we'll use this sometimes in clinic because of just the fatigue factor. It does have several domains such as physical functioning, physical and emotional limitations, social functioning, bodily pain, and then general and mental health. And from those, you can get composite score for all the physical components, and then a general composite score for all the mental components. And so a question on this assessment might read such as, over the last 4 weeks, how does your health limit you in moderate activities, such as moving a table, pushing a vacuum cleaner, bowling, or playing golf? So again, it's not actually the activities per se themselves, it's the ability, the physical functioning to complete the activity. We see that for Mrs. Jones, that her physical component score is around a 45, and her mental composite score is around a 62. With this scale, it's flip of the ALS AQ40. So a 0 is actually their lowest level of health. So for her, physical functioning is lower, where 100 indicates higher level of health. So a 62, she's doing better mentally. And if we look at that and compare the two, we've got similar results for the ALS AQ40 and the short form 12, but neither of these really hone in on some more of those global factors of quality of life. It's all about that physical functioning. So we're going to talk about global quality of life assessments. The two that we're going to highlight here with Mrs. Jones is going to be the sequel direct weight, or the schedule for the evaluation of the individual quality of life, and then an ALS specific one. So the sequel is not ALS specific, but it is a global measure, and it utilizes a semi-structured interview format. And within this one, the client is going to give you the 5 most important domains or cues or factors that they feel define their quality of life. So they're defining what's important to them. And then based on that, they're going to give you a Q level and a Q weight. So basically their satisfaction level, and then their perceived importance level. And their perceived importance is in relationship to all the other factors. What we see from Mrs. Jones is that spirituality, marriage, family, gardening, and socialization are the 5 most important factors that influence her quality of life. And when we think about that, the health-related components or the health-related quality of life assessments, they didn't really pick up on any of these areas, did they? But when we see this, we can now say and know with Mrs. Jones, okay, these are the areas that we need to be talking to her about. These are the areas we need to be asking questions about and evaluating and making sure she's still able to complete them, because this is what's important to her. This is how she defines quality of life. And within the sequel, it is a 0 to 100 scale again, 100 being that's the best, you're happy, and the way you get the general index score at the bottom is it's a formula for the way that they perceive their Q level and their Q weight. And she rates hers about an 88. So overall, her global quality of life for these areas that are most important to her, she's doing really well. When we think out of 100, that's the best she could be. So 88 is really ideal. She's doing great, but what's important to her? Her faith, her marriage, her family, being able to get out and do some leisure and gardening, and then socializing with her family and friends. And that's what we know from Mrs. Jones is most important based on this. It's not her ability to use her arms and her hands necessarily, although it takes that to be able to do some of these. But what's important is those components that are more global and existential in nature. Okay, and then we have the ALS-SQOL, which is a disease-specific global quality of life assessment. And this assessment has different domains that are already identified for you. So within the sequel, the client actually identifies what's most important, and they give you those cues or factors. Within the ALS-SQOL, they give you the factors, or they give you the domains that make up negative, or the makeup includes negative emotion, interaction, intimacy, religiosity, physical functioning, and bulbar. So it does have a physical component, but overall, there are more global domains within this measure, and they're not focusing on the physical functioning and the strength components to complete the task. They're focusing on your ability to interact with your environment and spend time with family and friends, or intimacy with your spouse or your loved one, and that includes sexual intimacy, or your faith, your religion. Are you able to go to church, or is you able to worship in your home as you so desire? And so this is why this is considered a global quality of life assessment. And these are on a scale of 0 to 10, a 10 being the best possible score and a 0 being the lowest possible score. And the average score for Mrs. Jones is a 7.37. So it's, again, globally, she's rating her overall quality of life really high. And when we look at all the different areas, everything's pretty high. The lowest ones are intimacy and bulbar. And so I would imagine she just feels like her speech is a little bit slower. And then as far as intimacy, I know fatigue is an issue for Miss Jones. So she may have just difficulty spending the time that she wants to with her husband or family and friends, because she just does fatigue quickly, especially towards the end of the day. So this one's global. It gives us areas that we can look at, and it's picking up on some of those components that are important for Mrs. Jones that we know of from the sequel. So we know that marriage is important for her. We know that socialization is important for her. And so and we know that her spirituality is important to her. And those are all also included within the ALS SQOL. So when we compare the different assessments, it's just our frame of reference. How are we going to evaluate quality of life within our clients? And then based on the results, how can we best help them meet their needs? And we know from the literature with our patients with ALS that global quality of life, it does tend to stay the same, and that they tend to define quality of life more globally speaking versus the physical functioning and the strength. What does that mean for us as OTs? So we really need to be looking for those overarching themes and focus on that. But then we also need to make sure we communicate that to the healthcare team, so everybody's on the same page and everybody's working towards that client and family-centered care approach and what the client wants and what their goals are. But then we also need to make sure that the family's aware of those cues as well, because oftentimes we know from literature as well that the family may perceive X as being most important, where the patient or the client may say, it's really Y. And so we want to make sure that they're talking, that they're communicating, and that they're on the same page as well for what's most important for not only each other, but also that dyad. So basically that caregiving unit as well. And that's also important for us to remember when we're treating our clients with ALS.
The last thing we would like to talk about in our presentation is our findings' impact on professional practice. Occupational therapy practitioners have the unique skill set and ability to analyze an individual holistically to determine factors of life most meaningful to the person. OTs understand that a meaningful occupation to one person may not be meaningful to another person. Thus, we must tailor our assessments and interventions to each person that we treat. PALS are no exception. We must understand what is important to them and intervene accordingly. As we have discussed previously, there is a need for a consistent and holistic quality of life definition and a more clear distinction between health-related quality of life and global quality of life when treating PALS. Understanding how quality of life changes throughout a PALS disease process is imperative, and how an OT utilizes various assessments and subsequently treats a patient with ALS. Knowing that global quality of life factors are typically the most important factors to PALS, OTs should consider utilizing disease-specific global quality of life assessments when working with PALS. These assessments more accurately measure quality of life for PALS that may enhance client and family-centered outcomes for these individuals. Now that we have presented you with all of our findings, we would like for you to consider these post-test questions. I will pause for a few seconds between each question to give you time to think about your answers. Number 1, briefly explain the difference between global quality of life and health-related quality of life. Number 2, in your opinion, are health-related quality of life assessments or global quality of life assessments more beneficial to use with PALS, and why? Number 3, list one assessment that could be utilized to identify health-related quality of life within PALS. Number 4, list one assessment that could be utilized to identify global quality of life within PALS. Number 5, why is quality of life important in PALS? Number 6, how does knowledge of the different quality of life definitions impact practice as an occupational therapist? Number 7, how will you personally use the information discussed today in your practice? Number 8, which quality of life assessment discussed today are you most willing to use in practice? And finally, following today's presentation, how has your comfort level changed with selecting quality of life assessments for patients with ALS? And these are our relevant references. So on behalf of our entire group, thank you so much for listening, and we hope that you found our scoping review insightful.